Tēnā koutou, tēnā koutou, tēnā koutou katoa, nō mai haere mai, and welcome to Maxim Institute's webinar, Euthanasia and the Illusion of Choice, a discussion about some of the issues raised by our paper that we recently released. Not coincidentally, it has the same title, Interrogating Choice, Euthanasia and the Illusion of Autonomy. We'll be talking about a number of issues during this conversation, including what our End-of-Life Choice Act really means for patient autonomy, how palliative care affects the decisions at life's end, ethical challenges facing healthcare professionals, and also, perhaps in a wider sense, the issue of death, how we address it as a society, how we ignore it, how we're not able to talk about it, I suppose, deeply. Joining me is Maxim Institute's research manager, Maryanne Spurdle. Welcome, Maryanne. Maryanne holds a Master of Public Policy from the University of Auckland, a BA in Communications from California State University at Fullerton, and is a World Journalism Institute Fellow. She held a variety of positions before coming to Maxim, but has been really, really great in, I think, galvanizing the discussion of euthanasia in terms of interrogating what choice actually means. So I'm looking forward to unpacking some of that stuff with you. We're also thrilled to welcome Professor Megan Best. Hey, Megan, kia ora, g'day, I think, from Australia. Nice to see you. Professor Megan Best is a research associate with the Institute for Ethics and Society at the University of Notre Dame in Australia. She has a clinical background in palliative medicine, and her research interests include spirituality and healthcare, existential suffering, psycho-oncology, whole person care, and bioethics. And much of her research has been taken on board over in Europe and also in Australia. I think you were saying you just before we started, you just got back from a book launch in the Netherlands. So I hope you're sort of settled a bit and ready to join us with this, Megan.
Absolutely.
Wonderful, wonderful. Well, let's just kick things off, Maryanne, in terms of what's the legal, practical status of euthanasia in Aotearoa, New Zealand? And also, how does this affect its application?
So the law we have here has been active for about 3.5 years. And what we've legalized is both voluntary euthanasia. And so voluntary euthanasia is where you have a medical professional actually administering it. And then assisted suicide is where you have them prescribing a drug and you take it yourself. So only about 10 other jurisdictions have legalized both, and there might be about half a dozen, including some with states such as Australia, that haven't. To be eligible, you have to be terminally ill, 18 or over, citizen or permanent resident, and have a 6-month prognosis. And also the suffering must be something that you do not consider can be relieved in a manner that you consider tolerable. So suffering, it's subjective, but that's in there as well. You have to have 2 doctors sign you off. And if there's any question about competence, they may refer you to a psychiatrist, but that's not required. What we don't have that we have in a lot of places overseas is a wait period. So some places you have to wait for a couple weeks after you apply, or you have to apply multiple times for it to proceed. We don't. The quickest time from application to death is just 2 days. So we have
2 days.
A very quick, yes. The most common time period is 14 days. So it can be quite quick. The oversight is done by a registrar before the euthanasia happens, and the review committee is supposed to look at death reports after. So that's kind of how it takes here.
In terms of that legal framework that you've outlined, how does it affect the application or the practical side of it?
As in, people can and cannot.
Yeah, I guess you've mentioned, for example, the speed.
Yeah,
that's something that other countries, they say there's got to be a 14-day cooling down period.
Often.
Yeah.
So in some ways we're more liberal like that, not having the wait period, so some places with liberal laws like Belgium will require somebody be sent to a palliative care team for assessment.
Right.
So the options are kind of there on the table. And part of what this paper is looking into is how the options here, some of the liberal side of things actually means that people can't make the best choice because they don't have the best information, which is what we'll get into, and then the best options.
All right, thank you, Maryanne. Megan, again, great to have you with us. You've actively campaigned against euthanasia in Australia, where most states recently legalised it. In terms of what Maryanne's outlaid as the framework, is any of this resonating with you? And how has your work as a palliative care specialist informed your stance? Sorry, this is a triple header. And I think for those who don't know what palliative care is, can you just give us a quick summary? No, not much work to do there, Megan, but I'm sure you're up to it.
Thank you very much. Palliative care is specialised care for dying people, which aims to maximise the quality of life and assist the patient and families and carers during and after the death. Its intention is to liberate patients from the discomfort of their symptoms so they can focus on the things that are really important. And it neither hastens nor defers death. So an old slogan we would have from palliative care is, we help you live until you die. And many members of the general public may not realise that most members of the palliative care community are actually opposed to euthanasia and physician-assisted suicide. And the reason we have that, I think, is because we know that involvement of palliative care can completely change the end-of-life experience. But we do know that there are whole huge areas of New Zealand where people don't have access to palliative care. Particularly once you get outside of the cities, there's a real lack of it. And if we're talking about choices, if you don't have any specialised care to help relieve suffering at the end of life, do you have a true choice if the government's willing to provide you with euthanasia but not with palliative care? So I don't know that there's a free choice if that's the situation. And I think the reason, one of the issues is funding. So 2 of the state premiers in Australia have actually said quite clearly, we can't afford to give everyone palliative care, but we can afford to give you all assisted dying. And what we've seen in my state,
they've actually framed it that bluntly as a cost issue.
Yes, and in New South Wales, the Labor government slashed $150 million from palliative care funding in the 2023-24 state budget, and at the same time put $97 million into the implementation and operation of assisted dying. So there's been very clearly a shift of focus to funding assisted dying instead of palliative care. And really, the legalisation of assisted dying completely takes the government off the hook when it comes to providing high quality end-of-life care.
Megan, I want to ask you, as you survey the situation in New Zealand, is this where Australia was at a few years ago, or is there a different configuration that raises questions for you?
What in terms of New Zealand now undergoing the review, do you mean?
Oh, just in terms of the the framework that Maryanne's just sort of laid out, and what you're saying about the Australian experience, where in typical Australian fashion, the premiers are being quite blunt. In New Zealand, we tend to be a bit more mealy-mouthed about such things. It's more an absence rather than an assertion. But as you look at the New Zealand, the New Zealand arrangements, which seem to be a mixture of things, so international features, do you think, well, what you're describing in Australia could be something that would happen in New Zealand, where they just
Absolutely. We see very similar patterns around the world with reduction of safeguards and liberalisation of conditions for euthanasia over time. What happened in Australia, which is slightly different from New Zealand, is that we legalized assisted dying on a state basis. And as you know, we have many states, and rather than have one law which was then reviewed after several years, what we saw was liberalization of assisted dying as it went around the states. And if you look at the jurisdictions where assisted dying has been liberalized, you see things such as reduction of barriers to access. Originally in Victoria, the first state to legalise assisted dying in Australia, doctors weren't allowed to raise the topic. They could only discuss assisted dying if the patient raised the topic. And then subsequently other states removed that because proponents of assisted dying saw safeguards as barriers to access. Other things is initially doctors had to have specialist knowledge in the patient's disease when they told them how long they had to live and what their treatment options were. And that is also no longer a requirement because it was framed as a barrier to access. So now I've known general practitioners providing assisted dying saying, well, I had to look up a book to learn about this disease so I could work out how long the patient had to live and what their treatment options were. So obviously the quality of advice is going to be much worse in those situations. But once again, this safeguard was eroded. Originally, patients couldn't choose between assisted dying that was self-administered and that was administered by the doctor. But once again, that was seen as discriminatory against people who could take medications. So now patients have a choice. And we know when there is a choice, more patients choose doctor-administered assisted dying, and it's more common. And I think that's because it gives assisted dying a false legitimacy when it's administered by a healthcare professional rather than a medication you take or a poison you take yourself.
Even Megan, if it's a healthcare professional that had to look up in a textbook the disease or the condition and the prognosis.
Yes, what we're seeing in Australia is a complete reframing of assisted dying as a legitimate healthcare option, and we are seeing changes in the way people talk about it, the language, and so we use euphemisms. I mean, assisted dying, I would have thought as a palliative care physician, that's what I was doing, was assisting people in their dying, but it makes it sound like something quite benevolent. It doesn't sound like you're actually murdering somebody, which is the best description of what's actually going on. Well, so I think
there's a linguistic difference, isn't there? Because dying is in a sense passive. You're submitting yourself to a natural process, whereas euthanasia is an active event, as you say. Look, I just I wanted some of the things we're discussing here perhaps might be provoking questions. Now, if you're watching, you have a question, don't hesitate to enter it into the YouTube live chat or in the comments on Facebook and LinkedIn. We will have about 20 minutes to answer your questions. If you do a really good one, I'll even insert it into the conversation now. So there you go. The bar is set. Maryanne, what's interesting to me and what Megan is saying is that there's the sense of access to a consumer choice, and you've spoken about this, framing euthanasia as a sort of a consumer choice. New Zealand's law is called the End of Life Choice Act. This paper questions the quality of choices offered and calls autonomy an illusion. Now, it sounds counterintuitive, but can you explain for us how more choices can actually negatively impact the choices that are available?
Yeah, because choice on its own doesn't immediately improve your options.
No,
it sounds like it should, but if you've played a game of, would you rather,
and
you put out a couple options there.
It's quite unassailable too. It's like, well, who's not for choice? I mean, we live in a consumeristic society where it's like, well, I choose to be who I who I want to be or whom I think I should be. It's all about my choice. But there's more to it than that, isn't there?
Yeah, because as Megan's pointed out, even with the funding in certain states, the rationale for allowing one option shifts when another option's on the table, and the funding can shift. So there's always trade-offs. And especially when it comes to somebody making an end-of-life choice, their options are only going to be as good as the information they have. So if you don't know what palliative care is, or if it's not available, then it's not the same type of choice as somebody who understands what a natural death is, has access to palliative care, and then here are all the services that the healthcare services provide. If some people don't have equal access, then it's not the same choice. And as they've seen in Australia, you've actually got funding coming away from palliative care and into euthanasia. Well, that's fewer and fewer people who can access palliative care. And so that's a choice they don't have now. In New Zealand already, we only have half the number of palliative care specialists we need. That was a couple years ago. The numbers are getting worse. We're aging. There are fewer and fewer people working in palliative care. There are changes that the Ministry of Health would like to make that would actually make palliative care less of an option. The review that came out last November made it clear that the ministry would like to require doctors to participate in referrals to a level that they aren't now, which erodes conscientious objection rights.
Oh, right. So if you're a doctor, you have to offer this.
You have to participate by, providing referrals, doing the paperwork. You can't just say, this isn't something that I participate in, but you can contact these people and So the ministry's take on that is, and also for care homes, they would like care homes to be required to offer euthanasia on site, even if their own staff don't perform it. Well, that is, like Megan raised, they are pushing access. They're saying access should be as stress-free as possible. Somebody shouldn't have to go off-site if they want euthanasia because it's a consumer right. That's the wording in the review. Well, that actually
that's where you get
impinges on others' rights.
Yeah, that's where you get also that understanding of, this is a consumer choice rather than and
it's just another option on the shelf. Without understanding that actually, and this is the key thing for expanding access, is you're actually limiting other people's choices. People literally leave the field of palliative care, and care homes, some of them will not operate if they are required to do that. So you're actually going to be taking services out of the health system by making requirements.
Reducing choice by requiring this option.
Yeah, so there are a number of issues around that. The other thing that this paper goes into is saying it's somebody's choice completely overlooks the fact that we change our minds. And as somebody, especially people who receive palliative care, as they have some support through different phases, as they have good information shared with them, story after story, Dr. Catherine Mannix's books, palliative care specialists who I've heard from, they've had people who wanted to die receive the support that was going to help them through the next phase, and then thank them for not encouraging them down that path, because what they needed was, counseling or relief physically, just knowing they're not going to be alone. So saying that somebody has a choice, yes, but do they have the right information? Because we change our minds. And when you can access euthanasia in 2 days, what kind of choice is that?
Yeah, and also the Megan, I want to bring you in on this as well. There seems to be a very limited understanding of what it is to be human. That we might make choice A, then we go to choice C, then we think, choice B might be the better one for me. Megan, Maryanne was talking about people who once they encounter palliative care, they're actually really pleased that they didn't choose euthanasia. Have you encountered that personally, professionally? Tell me a bit about that.
Absolutely. I think one of the big tragedies about the assisted dying debate is that it's taken focus away from providing high quality end of life care. I've worked in palliative care many years, and I recognise, and it's clearly shown in palliative care research, that when someone asks for assisted dying, it's a cry for help. It's a statement of being unable to cope, and it's the first thing you should say when someone raises the possibility of assisted dying, or saying, I don't think I can take much more of this, or I just wish it was over, or I just wish I was dead. Even, it's the first thing you should say is, what's wrong? How can I help you? Because we know that that what we call desire to die statements are extremely common in the end of life. We've known that, and these assisted dying laws are written with an absence of understanding of the normal end of life trajectory. So to give you an idea of how common it is, and how uncommon it is that it ends up with someone using assisted dying, is there was some colleagues of mine in Victoria over a set period took note of how many patients expressed this desire for hastened death, and there were 40. And of those 40, only 7 actually started asking about assisted dying specifically, and only 2 decided to take up the offer of assisted dying after going through the system. So we know that this desire for hastened death is common, and the psychiatrist Harvey Chochinov in Canada has shown that people change their mind over time, and it's not even necessarily due to palliative care. We have good days and bad days, we all do. And I once had a patient came into the clinic. Euthanasia wasn't legal at that time. And she said, oh, I just wish I was dead. And she told me about how terrible she felt. And then she said, I just wish I was dead. And as a conscientious young doctor, I said, well, I think I should let you know we don't do euthanasia here. And she looked at me shocked, and she said, do you think I'd talk like this if you did? So obviously she wasn't asking me to kill her. She was just expressing her distress. And that was the day I realized that when someone says they wish they were dead, they are not asking you to kill them. And we also know that when palliative care is introduced and it gets an opportunity to start doing its stuff, people have a reduced desire to die. It's a very clear association. But I don't know of any assisted dying laws that insist that someone receive palliative care before they're allowed to make their choice. And I think that the New Zealand situation, where someone can be killed within 2 days of request, is very dangerous, because even though those people might, with full mental competence, say, I want assisted dying one day, well, 3 days later, they may have changed their mind if you just withheld the poison. So I think it's a tragedy that people are being killed prematurely because of lack of safeguards.
And it's Megan, it's that I want to bring you in on this as well, Maryanne. It's we're talking about safeguards, but in fact, it's actually, I want to go back to the point that I raised earlier, which is that as human beings, we'll go through a bit of an arc to get to a decision, and the brevity between someone saying, look, I want to die, and that actually happening in our country, it doesn't account for, it's often said that life is a journey. Well, it seems that death is a journey as well, and it doesn't make any realization of that. Maryanne, you raised the issue about there being a cool down period in other jurisdictions. Can you tell me a bit about that? But before you do, I want to say I'm not seeing any questions yet. What do you think about the fact that it's possible, or it's been actually documented, that it's been only 2 days between someone expressing a desire to die and them being euthanized? Do you think that's reasonable? Do you think that is safe? I'll use the word safety because I think this is about people being in a place where they're held in some way, that they're consoled, not just, oh, I'm at the supermarket, I'll make a consumer choice. Let's get back to other jurisdictions. I think Oregon is one, isn't it, Maryanne?
Yeah, I think most of them, and I don't have the list here of how long in each place, but it's common to have a couple of weeks cool down period. Reading the ministry's review, it's very clear that when they have the option, in fact, it's spelled out, because they said when they looked at the option of having a cool down period, they admitted that and some other things would increase safety, but it would also decrease access. So they said, because it's a consumer choice, we're going with access. Now, the safety aspect is not just hypothetical. This is something that the review in November didn't address, was that 2 of the 3 original review committee members, the people who look at death reports, they're no longer on the committee. They both asked questions that couldn't be answered. And one of them was around gaps, conflicting information, and concerning information in the death reports. So they were seeing things that either there wasn't evidence that this person hadn't been checked to see there was no coercion, or things like prognosis and diagnosis hadn't been put in there. So when they raised this, the ministry told them to assume nothing's wrong if there's no information. Well, one of the reports they got showed that somebody who didn't speak English possibly had dementia, which should have disqualified them right away, and didn't have an interpreter, had been euthanized. Now, you've got to ask, how did that happen if there are actually safeguards? So a cool down period is just one of many things that should be in place, because the reality is there will be people coerced into this, and there probably have been already. Because how does somebody who doesn't speak English, hasn't had an interpreter, that there's no informed consent there?
Yeah, that is and I'm surprised that people haven't made as much of that as they should, because again, I think our concern is for vulnerable people. And if you are in a position where, say, you have a condition, perhaps you have dementia, you don't speak the language, you're in another
that should be disqualifying.
That should immediately.
Anybody who's got a terminal diagnosis, like, you're vulnerable.
Yes,
that's a lot to take on board. And to say you don't have dementia, you seem to be coherent. Even want that, then sure, you should. Yeah.
But having said that, even and getting back to that arc around, it's like, oh, all I want to do is tell you I want to die. I don't want you to help me to die. This is the way I feel at the moment, and let's work through this. So that's that is alarming, Megan. And you've got some quick questions are coming in now, which is great. So thank you very much. We're going to get to those again. Please keep those coming. YouTube live chat, Facebook and LinkedIn in the comments. In terms of Megan, we often hear that palliative care and euthanasia are 2 different topics, 2 different services that don't have to be in competition with each other. But what's the experience been for Australian physicians? And please tell, I think some of the anecdotes here that we're hearing really encapsulate the issues that we're trying to grapple with.
I think there's a lot of confusion between the 2. Some hospital administrators are insisting that assisted dying being carried out on palliative care wards, and people are very scared of dying, and they've always been scared of palliative care because of its association with dying. And now they think that assisted dying is part of palliative care. It's even worse, which is such a shame, because it makes people reluctant to access something that could really help them address a lot of their fears at the end of life. But I think many proponents of assisted dying want to confuse the 2 because, as I previously said, there's this attempt to give false legitimacy to assisted dying by pretending that it's part of traditional, healthcare, that it's a respectable end-of-life option in terms of end-of-life care. Sadly, some palliative care doctors do support a euthanasia, which makes it even more confusing. But I think what's happening, particularly I'm seeing this in younger doctors, is that although assisted dying was brought in on it was insinuated that this is something that's going to be, the very last resort in instances of sort of hopeless suffering. I think rather than seeing euthanasia as the last resort for suffering, it's now being seen as the only treatment for suffering. And we're seeing junior doctors, as soon as the patient says, I wish I was dead, they say, well, here's a referral to the assisted dying assessment clinic. And I think that is that's tragic that is happening.
Yeah. And I think too, I was just mentioning earlier that as a society, we prefer not to talk about death. We prefer not to talk about suffering in some way. And so do you feel that part of this, and I want to maybe get a bit philosophic, a bit theological, that we don't really have a theory of suffering as a society, as theory of death, where death fits in. And so this is part of the intractable nature of these questions. Megan?
I think there's a very poor understanding of suffering. There's we talk about suffering without defining what we mean, and we confuse it with pain. And even though two people may have the same amount of physical pain, our existential interpretation of the pain can increase it. So you imagine a woman in labor. She knows she's in pain because the baby's coming. Soon the pain will stop. She'll have a newborn. Whereas a woman with cancer knows the pain's coming from the thing that's killing her, and it's not going to go away before she dies. So they might have the same amount of physical pain, but the woman with cancer is suffering more because of her interpretation of the meaning of that pain. And so we have people who don't realize what a complex thing suffering is. And I think that many people have stopped thinking about the existential or spiritual side of life long before they face their own death. And we know that diagnosis of a life-limiting disease such as cancer brings to mind existential questions such as, what was the meaning of my life? What happens after I die? How will my family cope without me? And we require spiritual resources to answer these questions. And if we don't have those resources, some people don't even have the vocabulary to express the distress they feel when they realize their life is limited. And they're very scared. And you can't control death. I mean, we're all going to die, but you can control the timing and manner of your death. So what I think we're seeing is a societal death wish, in that we're scared of death. We can't stop it. So let's control it the only way we know how.
And it's almost as if there's, Maryanne, these questions are so large, but the only apparatus we have to deal with them is choice, is a consumer, I guess, approach, and also access. It's all about access. I need to have access. What are you hearing from within the community of end-of-life care physicians, etc., about the use of palliative care? And I think because I recall we've been talking earlier, there was one person who said that actually it made the death experience, it was almost serene.
Yeah, this was a journalist who just a couple of weeks ago in New Zealand wrote about a hospice experience with her brother dying. Excuse me. And she said there was no better place he could have been. She talked about the peaceful experience of it, the place. His family and friends were welcome, like a very different experience than being on a busy hospital ward. Some people can't die at home because they need higher level of care than the people in their home can give them. So hospices provide spaces, they provide training for people who are in places like hospitals and providing in-home care. And Megan knows more than I do about what exactly is all available. But the people I've spoken to who've had family members die in hospice have had nothing but praise for it. There's been no traumatic experiences mentioned. By contrast, people I know people who have gone through euthanasia, there are very mixed feelings among family. It's not a universal, everybody came together and did what they could, and this person had all the support they needed. There's stories of like unaddressed loss. And I think those are issues that, we can't really address in a paper like this. That those are very, very philosophical. Those are stories that are coming out as people are experiencing it. But that's something I'm observing.
Megan, is there any research that you've seen about the impact on families of euthanasia? Just that point that Maryanne raised. I'd be interested to hear.
It's early days to get a lot of research in Australia, but if you look at an international level, it's quite mixed. I mean, let's be frank. Some families love euthanasia. Death by appointment. None of that sitting around in the hospital waiting for someone to die. If you've got a busy life, death by appointment's very convenient. But I think the choice for euthanasia is the patient's choice, and not in Australia, you don't even have to tell your family members that you've made this choice. So there are definitely some family members who feel very conflicted, who it's in a way, it's like, it is suicide. I mean, it's physician-assisted suicide. Families have questions. Is there something I could have done? Did I fail this person? Could we have done something differently to prevent this? If people feel very strongly that assisted dying is wrong on a theological or philosophical basis, people may feel complicit if they stay with the patient, if the patient asks them to be there at the death. We see this in healthcare workers, chaplains, where patients want to have someone with them at the time of the death. There's these very distressed healthcare workers saying, am I complicit if I stay with my patient, or if I continue to look after my patient who's made this choice with which I disagree? Family members, I've received letters from family members who didn't find out about an assisted dying choice till after the death, and they are absolutely distraught because they didn't have a chance to see if they could change the mind of the patient. But once again,
indeed, even to be able to say farewells.
Yes, I think on the whole they are more orchestrated, and people do take the opportunity to have this farewell party. But there have definitely been cases where family members weren't informed and very upset afterwards. So it's a very mixed bag in terms of how families respond. But I will also note there are no bereavement services funded as part of an assisted dying package.
Yeah. Oh, that's a very salient fact. Look, we are discussing the Maxim paper, Interrogating Choice, Euthanasia, and the Illusion of Autonomy. Economy. Now, that was a Freudian slip, given that there's a cost-benefit to euthanasia that Megan has already outlined, and they're pushing it in Australia. Maryanne, your paper was in response to the Ministry of Health's own review of how the End of Life Choice Act has been implemented. What can we learn from the ministry's perspective?
I think words like consumer choice show how they are viewing it, very much in a utilitarian manner. I think also the attitude towards those who would not choose euthanasia comes across. And if this is, again, the paper is looking at how solid is the choice. Some choices are preferred over others. This is not free choice. And I'll just read a section where I address how the ministry speaks about communities that have different views. This is quoting from the paper. The Ministry of Health does not acknowledge that there are valid reasons to opt out of participating in euthanasia. It identifies that, and this is quoting the ministry's review, some communities' tikanga, customary values, are not aligned with or supportive of assisted dying, and that some held the view that the wairua spirit belongs to God and the body should be allowed to perish naturally, end quote. This belief, shared not just by many Maori, but also by many faith communities, is one that the ministry considers misguided. Regarding Maori whānau who consider euthanasia to be the same as suicide, they write, this is quoting again from the review, this points to a lack of awareness and acceptability of assisted dying within Maori communities and an urgent need for assisted dying to become familiar, understood, and accepted, end quote. And I asked...
So the translation is, you can have choice, but you have to have the choice that we prefer.
Yeah. My question
We'll
there is...
educate you on your choice.
Is it the Ministry of Health's job to normalise a practice that a significant diverse cross-section of New Zealanders objects to? I don't think it is. I think that is tipping the scales of choice and saying we prefer this one. If you don't prefer this choice, well, you should come around to our point of view and see that it is valid. If you're a health professional, you should be participating. If you're a care home, you should be offering it on site. That takes it too far.
So, yeah,
that's not a free choice.
No, choice becomes slight coercion that then becomes compulsion. We'll just read and want your questions to keep coming in. Questions on the YouTube live chat, Facebook and LinkedIn. That's in the comments. Got an observation here. And the quote is, we now know that when palliative care is introduced and gets a chance to properly do its thing, people have a reduced desire to die. That was a quote earlier, and it's from Rachel Pearl. Interesting. So again, what we're doing with this discussion, I think we're trying to reframe the notion of choice. We've got lots of gaps here in terms of the framework, the landscape in Australia and in our country. What do you think the answer would be? Megan, you have an unlimited budget. You have complete discretionary powers. What would you do to reorient this situation?
Well, quite frankly, I'd like to take the whole thing out of healthcare. I think if state-sanctioned killing is going to be available and it's based on choice, individual autonomy, why should someone have to be terminally ill to access it? It's surely, that denies the whole idea of self-determining decisions. So I would like to see a government office where people who haven't taken an oath to look after the best interests of their patient, to assess people to see if they are mentally competent in making this choice. And if they are, they can have assisted dying sort of prescribed for them. You don't need to be a doctor to prescribe these poisons or administer them. We've got capital punishment in the USA. Doctors aren't involved with that because it's against medical ethics. So I think that since killing our patients is the antithesis of the way traditional medicine is practiced, let's outsource it. Maybe politicians could run the clinics since they're so keen on assisted dying and decide who makes
what you're saying, Megan, is let's remove the shroud of legitimacy around it and make it what it is, which is it's actually about implementing death, not about not about.
If it's all about consumer choice, then it's a liberty issue, and we should not place constraints on the liberty of our citizens. So
maybe we could get it into the supermarkets, Megan. And forgive me, I mean this is a serious topic, and we are.
It is a serious topic, but you can buy euthanasia kits in chemists in Belgium.
Yeah, yeah.
And there's the question of why should it be managed by healthcare? Why doesn't it go through courts in the corner? Like, that's a legitimate question.
And I think there's also
Why are doctors expected to administer this?
Yeah.
There's there's also a I think there's an issue here too, in the sense that it's obviously the chat is warming up because we've got everything's getting warm in here. I'll keep talking, in the sense that there's a disparity there. Doctors are asked to, or they take an oath to ensure that life goes on, whereas we're asking doctors to end life, which is a really, really difficult. I guess it's the framework for that is we're asking them to do what they have sworn not to do.
Yeah, there's a very interesting paper that I read, written by some Canadian health workers, and they compared it to being in a car where you're going from drive to reverse, like just slamming the gears as you're assessing patients and trying to figure out what is best for this patient. Is it these treatments, or is it putting them down the path to euthanasia? And they say it grinds the gears, it creates burnout and stress. And this is among people who are actually providing it, let alone those who would rather not participate, who are having pressure put on them to do it.
Yeah. Look, Megan, we're gonna bring you in here because there's more to look at with you than there is with us at the moment. I think Maryanne's raised something about the ethics of euthanasia. Beyond issues of inequality, what ethical problems does euthanasia create for medical professionals? And also, we've talked a bit about families. So we've talked a little bit about families, but just patients, pardon me. But just the professionals. What problems does it raise?
I remember someone once asked me, when they do that euthanasia thing, do they sterilize the needle? And that captured for me perfectly how antithetical euthanasia is to traditional medicine, because of course we would never dream of injecting a patient with a needle that wasn't sterilized. But if the patient's about to be dead, it really doesn't matter. I think the best example I could tell you of how confused it makes medical ethics is that normally if somebody who's very sick comes into emergency, we do everything we can to save that person's life. But if somebody comes in after a failed assisted dying attempt, what are we supposed to do? Are we supposed to finish them off? Or are we supposed to do what we normally do and save their life? It's turned traditional medical ethics on its head when we no longer know that that healthcare workers are preservers of life. It makes it very confusing, and there is a lot of moral distress amongst healthcare workers because of this change in mentality. I would say even when we introduced palliative care, you could see people working in cancer medicine. We'd make people very sick, trying to cure their cancer. And then you turn around and say, well, we're not going to try and cure you anymore. We're just going to let you die naturally. That was a distress. But to go from preserving life to actively ending life causes even much more distress, and moral distress amongst healthcare workers is extremely high at the moment. I think also this idea of complicit. Am I guilty in some way if I am involved with an assisted dying event? If it's something with which I disagree, I think that causes a lot of confusion in healthcare workers as well. And I think the suppression of religious freedoms by the denial of conscientious objection is a huge problem. And people are leaving healthcare, they're leaving palliative care at a time when we need more people than ever because they just can't continue working in this setting.
Actually, let's get to, you've raised something that I've actually, one of the questions here or observations from Debbie Cunliffe. As a retired nurse who has worked as a Marie Curie, a palliative care specialist in the UK, We need to advocate for better palliative care services in New Zealand rather than euthanasia, which is not the answer. Where good palliative care exists, most symptoms can be managed. It is not our role to play God. Maryanne, one of the recommendations we make in our paper is to fully fund palliative care. It's not just about playing God, though, is it? Is this? I mean, again, the economics are here.
Yeah.
Is there an economic argument for increasing palliative care? Because it's not cheap.
And this is one of the interesting things about the choice of the ministry to not fully fund palliative care. For every dollar that goes into hospices, and they across the country have different contracts, each of them with the ministry, none of them are fully funded. But for every dollar that the government funds, then they get $1.59. That's been the estimate of services back. There are a couple reasons for that. One is it keeps people out of hospitals, out of emergency rooms, because they have touch points with people in their homes, or they might go to the hospice itself. And so the care they're getting is specialized for helping someone at the end of life. Whereas if you end up in an emergency room, they're going to do everything they can to keep you alive. They're not there to walk alongside you as you're dying. They're trying to keep you from dying.
And I think you mentioned actually in the op-ed that you did for Stuff about a woman who died in an emergency and ED.
Yeah, there have been reports on palliative care that point out that when people don't have access to it.
This was in a rural area.
Yeah.
Yeah.
So rural areas, Maori and Pacifica, have very subpar access to palliative care. It costs more to care for somebody in emergency situations when they haven't had that kind of support walking alongside them. And that's just the financial side of it. The other side of it is it's just much better care. Like it's something that 90% of us personally will probably be eligible for with an expected death. And then if you factor in loved ones who we know who are going to die, many of us have already walked alongside people as they're dying. And you get the benefits of palliative care there because there's counseling and support for family as well. So this is a service that nearly everybody in the country is going to benefit from, and yet it's not fully funded. Euthanasia, even if we end up at the higher end of the scale with 4% of deaths, that is not something that everybody is going to want to or need to access. So they're not like for like. Palliative care is just, we are all going to die, and most of us will benefit from those kind of services at the end of life. So the fact that it is patchily funded, it's just not acceptable.
Look, actually, you've touched on something, or one of the comments, observations here. Blair D says, offer of an access to palliative care is absolutely essential as part of informed consent. And also there needs to be a cooling off period, which is something that we've talked about. Other jurisdictions, Oregon, for example, has that 2-week cooling off period. We have that in consumer law for door sales. So if someone sells you something at the front door, there is a cooling off period, but we don't have it here in New Zealand for euthanasia. Megan, I'm interested to get to you in terms of where you see this possibly. Do you see a continued preoccupation with access, with cost in Australia? Where do you think they end up?
There's definitely, if you listen to the pro-assisted dying organisations, they still feel there's a lot to be done to improve access in making assisted dying a more prominent choice, availability for people who are terminally ill. Of course, like every other jurisdiction, the other thing we're seeing is people are starting to talk about widening eligibility criteria. So, the obvious case internationally is Canada, which has seen a 10-fold increase in assisted dying deaths since it was legalized in 2016, about 30% a year. And then they introduced assisted dying for people who weren't terminally ill. And they have So they have those, and we saw in the last report that the main reason some people accessed assisted dying on that track was because they had severe loneliness, and people who couldn't access social supports that they needed accessed assisted dying, as they felt that they didn't have a choice, that was the only thing that was really available to them now. And now they've once again modified their laws, saying that it's going to be available for people who have mental illness but no physical illness. We see in the Netherlands and Belgium expanding it to make it available to children. Netherlands has a variation of the law that makes euthanasia available to disabled newborns. And under that variation of the law, anticipated suffering of the parents.
There, Megan, in terms of with children, so who determines? Is it the child's decision? Is it what's the legal apparatus around?
So depending on the age of the child, if we have what's called the age of assent, where if a child is thought to be able to have a say in it, they are consulted, but essentially it's the parent's decision.
Mm-hmm.
With the variation in the law allowing for euthanasia of disabled newborns, the anticipated suffering of the parents is taken into account, as well as any anticipated suffering of the child.
Mm-hmm. Oh, that's really alarming.
So it's a very utilitarian approach to assessing
I guess
lives of living.
Yeah, you've raised a great point there, Megan, which is that we've actually been talking a lot about death, but what we're really talking about is what does life consist of? What is the essence of life? What does it? What constitutes that? Maryanne, we're coming to the end here, and I'd like to. Is there anything that gives you hope in terms of we are seeing a lot of issues that we're concerned about, but is it a conversation that you've had with someone in the medical profession, or what is it that that we can be?
Hard to pull some hope out of this. There are two bills that are private member bills that could be pulled. One is from the ACT Party that would remove that 6-month prognosis, and then we'd be getting into the territory Megan was just talking about, where non-terminally ill people are now eligible. So we might be looking at that. The other bill is.
I was asking
Tanya. Yeah. Warning, we could be going there. Tanya Unkovich has a bill that would require reporting around palliative care and better palliative care services. So the Ministry of Health, Health New Zealand would be held accountable. There would be standards set, and there'd be a discussion around that. And I think that would be a really positive step to caring for people and giving them actual choices.
Okay. Megan, is there anything? Oh, Megan's gone. That's fine. Look, I want to thank Megan for joining us and giving us an insight into the Australian experience, and also Maryanne, thank you for being with us. I encourage you, also those who ask questions, and by all means, this is not a discussion that we wish to end now. We'll keep it going as an organisation, Maxim Institute. Visit our website, www.maxim.org.nz. Our research paper is up there, along with other resources and columns that Maxim has built up on this issue. Oh, you're back. Megan, thank you so much for... That's all right. Thank you so much for joining us. And is there any resources that you would like to point people to, either healthcare workers or people who are interested in this issue?
I've written a guide for Christian healthcare workers called Living with VAD, Voluntary Assisted Dying. It's the Australian term for assisted dying, and it's on the EthiCentre website, ethicentre.com, along with some other articles talking about what makes a good death and palliative care, as well as other arguments discussing arguments for and against euthanasia.
Okay,
so
thank you.
EthiCentre.com.
ethicenter.com. Thank you very much, Megan. I don't know what the Australian for goodbye is. I guess I'll just say farewell, and we'll look forward to continuing this discussion in the various forms in the future. Thank you.
Keep up the good work. Thank you.
You too. And thank you for tuning in, and we'll see you again sometime in the future. Catch you later. Ka kite.